Hello, everyone. Thank you for joining us this evening for another session with the Virtual Global Spine. Today or tonight, I'm honored to host my colleague and friend, Dr. Najib Tecle, Assistant Professor of Neurological Surgery at Northwestern, an extremely talented surgeon all around, from endoscopic surgery to big scoliosis surgery correction. Tonight, he'll speak to us about management of adult scoliosis, adult degenerative scoliosis, and as well as the thought process that goes through it, and the how to approach adult scoliosis surgery and manage complications. Thanks, Najib, for joining us tonight, and the floor is yours.
Thank you, Nader, for the introduction, and it's great to be back. I want to try to talk about the topic that's fascinating to me, and that's been fascinating for us as physicians and surgeons throughout the years, adult degenerative scoliosis. And I want to try to emphasize a couple things: preoperative planning and surgical strategy, but we'll talk about the structure of the talk in a little bit. Now, scoliosis by itself has been fascinating for years and years. In a way, if we go to physicians of antiquity, Hippocrates, Galen, passing through the Arab physicians of the medieval ages, there has always been a fascination with scoliosis. But modern scoliosis is, in a way, a different disease, right? What we see here is more of an approach to AIS type problem. Modern scoliosis, on the other hand, is a disease of increased life expectancy and life expectation. So as beautifully illustrated here by DALI, the artificial intelligence DALI, people these days, it's not only that life expectancy is increasing, they also expecting more from life at more advanced ages. People in their 80s today want to do more. Some of them are coming because they're skiing. Some of them are they're asking more of life. They're asking to be able to walk more, and that's where the combination of these two things, an increased life expectancy and increased life expectations, meet together and make it that this pathology that is adult degenerative scoliosis is becoming more common for all of us in all our practices. Now, all of us who look at spines every day have that gestalt of a spine is balanced or a spine is not balanced. All of us, we look at these x-rays, we know that something is not adding up, right? These are x-rays of spines that are not really well balanced. And the way to approach this, people have looked at it in different ways, different approaches. But what I want to try to address today is how would I approach this from a complication minimization framework, and eventually we'll talk about planning when it comes to medical planning, surgical planning, planning your alignment, and eventually we'll go into some cases. But I'm going to ask this question to everyone attending. This is a 69-year-old female with debilitating back pain. She failed conservative treatment options. Say we've medically optimized this patient, and the plan is for a T3 to pelvis. Let's assume she needs only PCOs. What risk of complication would you code this patient? I'm gonna look in the chat just to see. So the question again, what are you gonna tell this patient? What's the risk of having a complication after this surgery?
Oh, Najib, you're starting with the easy case with the short segments. So you are planning. Can you tell me what kind of comorbidities this patient has? Is he diabetes? Has he got any other diseases he's suffering, chronic diseases?
Yeah, so for the
Because
sake of something like that, the assumption is this is a healthy patient, optimized from osteoporosis standpoint, optimized from a medical standpoint, no major medical comorbidities.
Okay. Nevertheless, I would tell him maybe even if it's a big surgery, it won't be his last. The rate of complication overall is pretty high in these patients. If you're looking to the literature, you easily find studies like 40% complication rate, revision rate is high. So I have to openly discuss with him that although I plan to do one surgery with many osteotomies, it's still there's a high risk that I have to take him back to the OR within a couple of weeks or months for any kind of revision, like screw misplacement, like neurologic deficits, like ongoing nerve recompression, wound healing problems. All these major or minor complications can lead to revision surgery.
And in a way, that's exactly it. The risk of complication is quite high, but how high it is. And if we try to figure out, like going back to the literature, what are the studies that have looked at this topic? To me, one of the best studies that looked at this was this Canadian study out of Vancouver General Hospital, where what's unique about this study is they looked at their data in a prospective and retrospective way at the same time. And when they did look at the data from a retrospective fashion, they found that the morbidity rate, the risk of having a complication, was about 23%. When they prospectively collected this data, they looked at prospectively what's the risk for patients undergoing surgery for adult degenerative scoliosis. They found that up to 87% had a complication. Now, not all complications are created equals, and we can see here from what they found, electrolyte imbalance was a common complication. They found like others like constipation, and there were others where more severe complications that go like cardiac complications, hardware failure, and things like that. And when I think about these complications in general, if we want to avoid them, if we want to try to minimize these complications, we need to be judicious about what are the complications. Typically, when we're talking about these complications, there are medical complications. They're typically intra and immediately post-operative, mechanical complications that are post-operative, and neurologic complications that are immediate or delayed. And complications can happen. This is a busy slide, but in a way, it's the way I frame these complications in the sense that this is a complications grid. So there are reasons that are preoperative, intraoperative, postoperative. So we start with medical complication. Are the patients optimized? Inadequate medical optimization can lead to increased risk of complication. If the patient is smoking, that predicts a worse prognosis from the standpoint of a pseudoarthrosis. Mental health issues, bone health issues, even weight. We know a BMI of greater than 35 typically associated with higher risk of complications. MRSA decolonization, has that been achieved? Now, intraoperatively, there's how do we reduce these medical complications? Of course, attention to details. You need good hemostasis, tissue handling. In a way, if you're not working in an area, reposition that retractor. Don't really keep the retractor open and in a way strangulate that tissue, using infection prevention strategies for most of us in this day and age, vancomycin powder, but irrigation and trying dilution as the solution to pollution in many ways. And post-operative VTE prophylaxis, getting these patients out of bed earlier, getting adequate rehabilitation, proper wound management, proper drain management. Now, from a mechanical standpoint, this can be a little bit different. Preoperatively, you could run into complications if the assessment of the alignment is inappropriate. Again, we run into the issue of bone health. Planning, do we really need a 3-column osteotomy? Can we do a little bit less and achieve the same goals from an alignment standpoint? What are your PJK prevention strategy? What are your hardware failure prevention strategy? Intraoperatively, mechanical complications can come from poor positioning. These surgeries, you can't do a scoliosis surgery on a Wilson frame, right? You need to be cognizant of how the patient is properly positioned for the surgery. Malposition of implant, how are we making sure these implants are properly placed? And eventually reconciliation. When we have a preoperative plan, how do we make sure that we've achieved the goals of this preoperative planning? Eventually, neurologic complications, are those that mostly happen intraoperatively, durotomy, and in no way we're gonna live in a world that is durotomy free, but if it happens, was it appropriately repaired? Spinal cord injury, nerve injury, how do you protect the neural element, minimizing retraction on the neural elements? And even if we talk about this group here, neurologic complications in the postoperative phase, like PJK that progresses to PJF, what are our strategies to minimize that? And as I think of this complication grid, what comes to mind is that you don't rise to the occasion, you think to the level of your training, you think to the level of your protocol. In a way, sure, we know these things, but if we're not preemptively thinking about them, if we're not preemptively ready to address these, in a way, we're not going to always think about them. And that to me brings the importance of a protocol, the importance of having specific methods, checklists, ways of making sure patients that are going through these surgeries are getting these issues figured out before they're in surgery. Because in many ways, the operating room is the last place to figure out the plan. The operating room should be about addressing and executing a plan that has been developed before surgery. At Northwestern, we've had this risk stratification or high risk spine protocol where everyone going into spine surgery, everyone that's gonna get a deformity type spine surgery is gonna go through this high risk spine protocol. And part of it is gonna be checking, okay, what's their vitamin D level? Are they optimized from their diabetes standpoint? Are they malnourished? We're checking their bone health. Is their BMI adequate? For select patients, they're going through psychiatric workup. This is what ensures that patients, by the time they're ready for surgery, they're going to have the optimum result. Not to say that that's going to lead to a complication-free outcome, but that is going to allow us to try to optimize and minimize the complications as much as possible.
Najib, a quick question. You show here and criteria. I know about that, of course, because I work here. BMI less than 35. Is there like a minimum threshold, like where if you're too cachectic or too sarcopenic, you can't have or it need to be optimized? And how do you optimize patients with a lower BMI?
So currently, the way it's built into the protocol is through an albumin or pre-albumin and nutrition screening test. However, the data is definitely there to support that patients with sarcopenia are at a higher risk of complication. And if in a way, it doesn't necessarily need to mean a BMI of 18 to mean that the patient is sarcopenic, right? Analysis of their muscle composition analysis, even the gestaltish approach where when you're going through their axial MRI, you're looking at those paraspinal muscles and you're seeing significant infiltration or fatty infiltration of the muscles. That tells you they're quite sarcopenic. Even sometimes if you see that they're like muscle envelope throughout the spine is not doing its job, you know that they are sarcopenic. And from that standpoint, these patients are definitely at the higher risk. Now, the more important question is how do you address that? How is a nutrition consult necessary? Can it solve the problem even if you do it? Do you need to check it again? And I feel that these are all questions that hopefully over the next few years, we're going to gain a better understanding for. Now we have the machine that in a way tests conductance through the arms and legs and comes up with muscle mass, and it helps you determine like, are these patients really sarcopenic? And in a way, we're collecting that data, but eventually we're going to figure out how do we use this data specifically? Do these patients need more preoperative optimization, or is this something that if they're going to have protein supplementation after surgery, they're going to do just fine? I'm going to move on to the next step that while medical complications are a big part of what we do, still from a cost standpoint and from a quality of life standpoint, implant complications, radiographic complications in the sense of rod fractures, PJK, these are the ones that are the most common, and these are the most impactful from the standpoint of affecting the patient's quality of life. Now, there have been significant research into how to reduce the risk of of hardware complication. How do you diminish rod fracture rate? Do you use cobalt chromium? Do you use a third rod, a fourth rod? And in a way, over time, we've seen that people have shifted to stiffer rods. As they shifted to stiffer rods, there was an increase in the rates of PJK. Then people talk about transitional rod, then use third rod, and eventually more novel strategies like tethers. There is definitely now evidence that tethering at the UIV +2 level, maybe also throughout the UIV +1, UIV, and UIV +2 level, does decrease the PJK rate. But most importantly, from that standpoint, what's helped the most in decreasing the PJK rate is gaining further understanding of the overall alignment. So I'm going to spend the next few minutes talking about sagittal plane evaluation, and I'm trying to frame this in a way that would be adequate for a resident or a fellow to gain a better understanding of what that exactly means. I'll talk briefly about coronal plane evaluation, how to go through for developing a surgical strategy, and then we'll present some cases so we can make this a little bit more interactive. So from a sagittal plane evaluation, we're looking at the patient from the side. The concept of the cone of economy was described by Debussy, and the idea is that if you're standing upright, you're not using much energy to maintain that upright posture. Within that cone of economy, you are not expending much energy. Now, as you start leaning forward, as patients become more kyphotic, which life is progressively kyphotic event. So as these patients are becoming progressively more kyphotic, we're asking their lumbar spine to do more. We're, in a way, from a physics standpoint, this is the concept of torque or lever arm or moment arm, where that force is being applied way at a distance from the axis of rotation, the axis of rotation being the bottom of the lumbar spine. And when a force is applied at such a distance, it has greater effect of the spine. And like the math that has been done around this stuff suggests that we're asking the lumbar spine to support moments in the order of 350, sometimes even in the order of 500 newtons. So that's the concept of spinal balance overall. But how do you address it in a more practical way? A more practical way starts by evaluating the spine. To me, it's a bottom-up type of approach. And most spine surgeons at this stage are familiar with these, but I'm gonna go through them in a little bit more detail. The pelvic incidence equals the pelvic tilt plus the sacral lordosis. What are these? The pelvic incidence is the angle between the femoral heads and a perpendicular in the middle of the sacral end plate. What does that mean? This is an intrinsic pelvic parameter, and I'll get to that in a minute. The pelvic tilt is the angle between this line, the same line, and the vertical, and it defines how tilted the pelvis is. And the sacral slope is just how tilted the sacrum is from the horizontal. So let's talk about these in a little bit more detail. I think when looking at these, when residents or fellows are first learning to think about these, it's important to visualize multiple instances of like, what does a high PI look like? And what does a low PI look like? PI typically is going to range between 30 and 80 degrees. There's no like normal value, but PIs that are higher do predict that those patients are able to compensate more. In a way, if you want to think about it this way, if a surgery doesn't achieve proper alignment for a patient with a high PI, they are able to compensate their way out of it. For a low PI, that's where you want to be more thoughtful about the alignment, because they might not be able to compensate adequately. So here I chose these two examples because also they have a similar sacral slope, and that's their PIs. And you can see how when the sacral slope is similar, eventually PI is gonna mean where does your sacrum sit as compared to your femoral head. A low PI means your sacrum is sitting closer to the femoral head. A high PI means that your sacrum is sitting further behind as compared to the femoral heads. And this is, again, this is an intrinsic pelvic parameter. In a way, this cannot be changed in the absence of a fracture or something like that. This is specific and intrinsic value. Now, pelvic tilt is the big variable where I feel that most people try to ignore it, especially as they're starting to learn about this stuff. And I want to encourage residents and fellows to start by looking at the pelvic tilt first. So what is the pelvic tilt? It is the obliquity of the pelvis. It's that line going from the center of the sacral end plate to the center of the femoral heads, and how oblique that is in comparison to the vertical. This is here, if you look at it, that's a normal pelvis. It's pretty vertical. A pelvic tilt to me that is less than 20, 22 is a normal pelvic tilt. A pelvic tilt is extrinsic to the pelvis, meaning you can change the pelvic tilt. And a good practice when you're trying to understand this further is try to stand up and think, how can I maximize my pelvic tilt? Technically, you're leaning backward. As you lean backward and you further bend your knees, you are able to bring that pelvis backward. And you see this patient on the right side here, you see how he's bending his knees and bringing that pelvis backward. So again, for residents and fellows, what I recommend for you to better understand this is think of it yourself. How do I maximize my pelvic tilt? If you stand up, start leaning your pelvis backward and imagine how the angle of your pelvis is moving backward, and see, okay, if I want to lean further, if you bend your knees, you can bring that pelvis even further backward. And my advice for people looking at this, and I'm going to tell you how we add this to sagittal alignment, start by looking at the pelvic tilt. It gives you the most information in the sense that this patient probably is balanced. This patient is probably unbalanced or balanced with compensation. And we'll get more into that in a little bit. Now, another idea when you're looking at an equation, from an engineering standpoint, you want to understand limit values. So limit values, you're starting to think, okay, if this variable goes to infinity, negative infinity, things like that. When you apply things like that to medicine, limit values are different. Limit values is a value where, okay, what does it mean if the sacral slope is 0? That's a horizontal sacrum. What does it mean what does that mean? That means the pelvic tilt and the PI need to be the same. And I'll show you what are the implications here in a minute. A good way of combining these is this idea of Berry's ratio. And I'll start by looking at the part on the right of the screen, where if you have the C7 plumb line going somewhere in between the femoral heads and the sacral and the end of the sacral end plate, that's a balanced patient. If that is happening in the setting of the high pelvic tilt, yes, the patient is balanced, but that balance is compensated. So this patient is managing to be balanced by retroverting their pelvis. And of course, if that plumb line falls in front of the femoral head, this patient, despite the high pelvic tilt, is not managing to compensate properly. Now, to me, this is, in a way, the most useful way of thinking about that, because it encompasses both ideas. It encompasses the idea of a pelvic tilt, where you start with your pelvic tilt. Is the pelvic tilt high? You're definitely falling here. You're either going to be compensated, balanced, or unbalanced. Is your pelvic tilt low? Then probably you're talking about the balanced spine. So, and then you look at the C7 plumb line, the SVA, where does it fall as compared to the femoral head, et cetera, et cetera. Now, that's the, in a way, more modern classic way of looking at that, but there's newer ways and newer methodologies of thinking about this. And I think a great idea is the idea of functional segmentation of the spine. Let me start by touching on some basic mathematical concepts. And these are the apex of a curve. It's easy. We're not going to define it geometrically. The other is what's an inflection point when we're talking about curve. An inflection point is a point where the tangent to the curve does go through the curve from one side of the curve to the other side of the curve. Now, if we think of the spinal alignment or the spinal curvature in terms of these, we have the lumbar lordosis is going to be defined as the angle from the bottom of the spine till the first inflection point, where the tangent to that curve is going to go through that curvature. And the spinal kyphosis, eventually the thoracic kyphosis, the inflection point is going to happen at the top of the the thoracic kyphosis. Now, what's very important in this analysis is geometrically, the lower arch of the lumbar lordosis, this angle beta, is equal to the sacral slope. And what does that mean for us? How can we take this concept a little bit further? It's again by trying to understand the limit values. Let's assume this beta angle is at 0, a patient that lost their lumbar lordosis. If that beta angle is at 0, the sacral slope is going to 0. That means the patient is trying to bring their pelvic tilt to the value that is their pelvic incidence. So a low value, typically less than 20, they're trying to bring it up to a value that's typically anywhere between 30 and 80. And that's how you see that why it's so important to have lumbar lordosis in the right place, one that is at the bottom of the curve, and how it does fit into this entire equation. Now, also, you can extrapolate this. Theta, this angle, is equal to the thoracic kyphosis. So in a way, if now you're increasing for some reason, you do a lateral approach, or you do an anterior release, and now you're changing this angle, you see how this angle is going to have a significant impact on your spinal kyphosis. And all of a sudden, these patients are at an increased risk of PJK just because the lordosis was placed in the wrong spot. Now, another newer concept that I really think is very helpful is this idea of spine morphotypes. And this is the Russelli classification of what do spines look like. We don't all have the same appearance of a spine. And what Russelli did was classify spines into 4 different morphotypes. So our type 1 and type 2 are those low sacral slope, low pelvic incidence. Type 1 has a short lumbar lordosis and immediately turns into kyphosis. And for this type specifically, if you need to give it lordosis, it needs to be really at the bottom of the curvature. Type 2 are those patients with physiologically flat backs. Physiologically flat backs means those patients are more prone to developing degenerative type disease when they're younger. You'll see patients coming in their mid-30s, late 30s, where they're developing disc herniation after disc herniation. Eventually, they get de novo scoliosis. Type 3 is, in a way, the average person, where it's well compensated. There's equal loading on the anterior spine, equal loading on the posterior spine. These do tend to age in a more harmonious way. And type 4 are those areas where we have a very high lumbar lordosis and compensated by a high thoracic kyphosis. And these patients, in a way, if you fuse them in the wrong way, if you mess up the angle for someone who's a type 4, if you fuse and stop and mess up, for example, the thoracic kyphosis, these patients are at a much higher risk of developing adjacent segment disease. So that's my take on the sagittal plane alignment. I'm going to briefly touch on the coronal plane alignment. It can take a lecture like by its own, but I'll just do 3 quick slides. So coronally,
Najib,
in a way,
Najib,
sorry, go ahead.
may I ask you, there was a question from the chat box.
Absolutely.
Can we make our what is the influence of environment of our genes for a good sacral slope or a good pelvic incidence? Can we send our children to yoga to optimize their parameters for the future? Is this a question of where you come from, where you live? What is your impression?
That's a great question. And in many ways, I don't know, but to me, it feels like it is more of a genetic component. It feels like it is mostly predetermined, so that pelvic incidence is not changing over the years. And it's like, it's kind of a predetermined value, which makes me think it's mostly a genetic value. It would be an interesting study to look and see if we can say for sure it is, like looking at x-ray, because oftentimes you'll hear the story in the clinic where people are going to tell you, oh, my mom had the same thing at the age of 40. My dad had the same thing at the age of 50, right? That's a common theme. You hear it all the time. Whether spinal morphology itself has to do with it, or whether the genetics are more related to something like connective tissue problems, or whether it is like the food you eat. I think that's a big unknown, and it would be interested to look into it, but I honestly don't know the answer.
Yeah, I don't know the answer either, but as an orthopedic surgeon, you learn that hip dysplasia should be treated as early as possible. You know these pictures, like 3-month-old children, 6-month-old children getting their correction, conservative treatment would be really great if we get smarter by time. This was just a question from the chat box.
No,
Thank you.
that's a very interesting question, and we'll see if we have enough data to look into it. But yeah, very interesting. So we'll move to the question of coronal alignment, and in a way, there was this big wave starting with the same group, Glassman's group in 2005, eventually going through the SRS Schwab classification of focusing on sagittal alignment, right? SVA, and people started thinking about that more because it was a better predictor of quality of life. But at the same time, people kind of forgot to talk about coronal plane issues. Although Glassman also published that a coronal shift that is more than 40 millimeters does lead to worse function, and eventually it does lead to worsening of quality of life. So in a way, it's something to keep in your mind as you're approaching these patients. How do we define it in the coronal plane? CSVL is the central sacral vertical line, and the C7 plumb line, where everything to the left is negative, everything to the right is positive. Typically, what we're looking for is less than 3 centimeters, ideally less than 2 centimeters of displacement. But more importantly, as we're doing our sagittal plane corrections, to me, what's important is not to significantly alter what the patient is starting with. In a way, we're trying, if a patient is positively balanced and you make them less positively balanced, they will probably do okay. But if while you're correcting sagittal imbalance, you take a patient from being positively balanced to negatively balanced, those patients are not gonna be happy with the result. So it's something to definitely keep an eye on when you're doing these corrections. And sometimes patients have this as their primary problem, so figuring out how to fix it. Now, two major classifications are worth noting. The Bow classification, where it mainly classifies these curves as type A, where the distance is like the coronal central line distance is less than 3 centimeters. Type B, where it is more than 3 centimeters, but the C7PL is shifted to the concavity. In type C are more than 3 centimeters, where the C7PL is shifted to the convexity. And the Obeid classification, which in a way combines the type A and type C bow curvature, because they are in a way treated in a similar fashion. The correction should be obtained at the lumbosacral junction, whereas correction should be obtained at the main curve for the bow type B. So now, assuming we have this good understanding of alignment, preoperative optimization, how do we develop a surgical strategy? We figure out our alignment goals. Next steps, to me, it goes in this order of you select your upper instrumented vertebra, lower instrumented vertebra, determine whether you need to do any osteotomies, and whether you need to do any interbodies. And before we get too carried away by these numbers, I want to talk about this patient. Let's talk about her. 73-year-old female with scoliosis. She has a very active lifestyle. In a way, she is doing horseback riding. She's been followed for this for a couple years now, and she has intermittent back pain. She's come into your clinic for left lower extremity weakness. And I'm gonna also ask for people to weigh in the chat and see what do you want to do?
So Najib, this is a nice case. Why I also invite everybody to write down the suggestions in the chat box. I just want to say, like 15 years ago, I was taught, tell these patients from my teachers, tell these patients there's nothing we can do. Let's ignore the scoliosis and look for one level or maybe two level, so we can minimize our focus and only treat short segment. Because in a 73-year-old patient, risk would be too high. Did your look to these patients change over time, or have you been taught from the start that surgery is an option?
To me, eventually in neurosurgery, you start in a cranially heavy world where people kind of look down on spine surgeon putting so many screws and rods. But yes, early in my residency fellowship, yeah, I was told that eventually it's an option for this patient. But that doesn't mean that I disagree with what you just said. I feel in a way, this is a patient that has a very active lifestyle. She has left lower extremity weakness. I think this is the acute component for her. It's not her back pain. So we probably should look for something to explain that. And for her, that's her MRI. So she had this synovial cyst and fits her symptoms. And I talked to her that, look, there is the option, sure, there is the option of doing big scoliosis surgery. You're having intermittent pain, but she was adamant about her back pain not being the issue. She told me, like, if I didn't have this weakness in my leg, I'd be just fine. And because this fit the symptoms, I talked to her, okay, what can we do about that? And we discussed the option of just going for the synovial cyst. And that's what I did. That's the cyst, that's the dura. And she completely resolved her weakness, completely resolved, went back to an active lifestyle. And eventually her back pain stayed the same. But in a way, by not only thinking about the numbers, not only thinking about the scoliosis, we can sometimes find smaller solutions that will address the patient problem and not put them through the risk of a bigger surgery. And the reason, again, I'm showing this case is to say that the Gestalt approach still has a role, in the sense that it's very important to listen to the patient. What is the patient saying? Is it their back pain? Is it a scoliosis type back pain, where, like, if they're walking, they're standing for long durations? Or is it something else? Can we do something smaller to address the problem? Granted, this is not necessarily the topic of this lecture, but I feel it's always important to keep the big picture in mind. Now, as we talk about eventually going to making the surgical plan, few pointers. How do you select your UIV? When we're talking about UIV, we're talking about the upper instrumented vertebra. To me, for coronal, there are coronal plane considerations and sagittal plane considerations. Typically, for the upper thoracic curve, you're thinking shoulder control. So as you derotate the spine, this is what you're trying to achieve, right? You're trying to put these shoulders, level them up. You want to avoid doing something like this where you bring the contralateral shoulder up. And I want to just show this again here, where if the shoulders are balanced at baseline, you have the option of not going higher. Typically, you could stop at your T4 level. But if the shoulders are not balanced at baseline, in that case, you're thinking about, how do I control that contralateral shoulders? Because the moment you derotate this patient, that contralateral shoulder is going up. So that's, to me, the consideration for UIV in the coronal plane. And the lumbar curve, it's typically the end vertebra, and like mostly sagittal considerations are going to be more important. Now, in the sagittal plane, in the thoracic curve, mostly it's simple. Don't stop at the kyphotic level. For lumbar curves, I tend to favor horizontalization of my UIV screws. I avoid the apex of a curve. Sometimes, if patients have smaller curvatures in the thoracic spine that appear flexible, good muscle envelope, I spare a flexible thoracic curve. I think there are newer ideas that are circulating about the UIV level in the sagittal plane, like For example, for Rousseli type 4 curves, there are preset points where you can stop at your L4, L2, but then if you stop at the lower thoracic spine, the overcompensation is going to lead to early PJK. So the recommendation is to go immediately to T4. I don't know that the data is there to support that yet, but these are things that are circulating in the community. Fractional curve fusion, is it an option to do a fusion that is selective? I think it could be an option to do a selective fusion, as long as we're telling the patients that, look, this might not be the end of it. And as long as their symptom is maybe a radicular type symptom, as opposed to a scoliosis type symptom. And the coronal plane, the considerations are similar for the LIV. For thoracic curve, we're looking at the most cephalad vertebra. The role for thoracic type fusion in adults also remains unclear. Like in AIS, we know the lanky curves with modifier C can be addressed with selective thoracic fusion. I don't think there's much role for something similar in adults, but that's also to be determined. Typically in the lumbar spine, your LIV, or for lumbar curves, the LIV, we're going to the pelvis in most cases. And it's very similar for the LIV when having like sagittal plane considerations. Let's talk about this patient. 59-year-old male with prior fusion comes to you like that, terrible back pain. It's been going on for quite some time, and some fractured rods. Because I have a higher resolution picture of these, the S1 screws are loose. What are the next steps? What do you want to look at, and how are you assessing this patient? I'll look at the chat too.
Yeah, and while we're waiting for the chat box, I want to ask, is there any signs of sacral insufficiency fractures?
No fractures, but there's hollowing around the screws.
Okay. So what is the SVA approximately like?
The SVA is 1.6 centimeters.
Oh, yes, I can see a 1.6. Oh. So usually it's the first thought I have is
I mean, I'm sorry, it's 16 centimeters. My apologies.
16, yeah. Now I've read it. The lumbar lordosis is far too little. It's a fixed flat back situation. So my first thought is needs a PSO, a revision going to the pelvis to restore the lumbar lordosis. You see the flexed knee. There's no compensatory mechanism in the lumbar spine, and the thoracic curve is flat. It's too straight. It will end up in a lengthening connection from the cervical construct to the pelvis. And for measurement, my planning tool will tell me what to do. I think it will be an L4 osteotomy, and in the lower thoracic spine and the TL junction, some posterior osteotomies as well.
Exactly, and this is exactly like what you mentioned, but I'm going to try to, for the residents and fellows, obviously this is a patient, I'll take it like in a different perspective. Obviously the patient is falling outside of the cone of economy. The SVA is at 16 centimeters. Even in terms of like C7 plumb line, gravity line, these are falling way in front of the patient. If we go back to what I mentioned before, look at the pelvic tilt first. This is high pelvic tilt. This patient is trying to compensate for something. High pelvic tilt, and his SVA is falling, or C7 plumb line is falling way in front of his femoral head. He is not balanced. Now, the next question is, okay, I want to address this. As I said, UIV, LIV first, then osteotomies, then interbodies. So question UIV, LIV, you're right. This is something he already has loose screws at the sacrum. It's going to have to go to the pelvis. The other component to this is UIV. Do I need to go past this point? And not necessarily. This is an area where, like, I got an MRI of his thoracic spine. We don't need to go past that point. Now, next step is going to be osteotomies. And to determine the need for osteotomies, we'll go for a CT scan, he's perfectly fused, then yes, he will need an osteotomy. There's no way he's budging without doing an osteotomy. And typically this is what we're looking for. So that's the patient in his current position. We're gonna go for an osteotomy and try to bring him backward so his head in a way is sitting on top of his pelvis. And eventually from a surgical standpoint, we're gonna end up with this. And if we look at like the before and after of this patient's correction, for me, for my 3COs, I do put a T-lift cage in there just to enhance the fusion. So if we look, I want to look at the pelvic tilt as the parameters just to reinforce this idea of looking at the pelvic tilt. You immediately see how this patient is, pelvic tilt went way down from 28 to 20. Now his SVA is much better. He's well compensated. His lumbar lordosis, pelvic incidence, they're matching. And definitely, this was a very happy patient of mine. Now, we can do another case, and let's see how are we doing on time. I'll try to be quick on the final case so we can have more discussions. Now, when we talk about degenerative scoliosis, you're not going to always run into your typical adult degenerative scoliosis, right? Sometimes it's a little bit more. This is a patient with Sherman's kyphosis and eventually a degenerative component that built onto it. Thoracic kyphosis at 86, and probably that's an exaggeration because the rotatory component of the kyphosis gives you the illusion that it is that big, but still, he is very kyphotic in the thoracic spine. Very high lumbar lordosis that tells you he's compensating. He's trying to bring his head backward. His pelvic tilt is at 8 because his problem is not in this region, and his CSVL is as plus 2.1 centimeters. Trying to understand UIV, LIV, fusion, whether we need to do osteotomies, interbodies. He's not fused, all his discs are open. So chances are we're not gonna do any massive osteotomies, a bunch of PCOs. On the MRI, just some cord signal change at the apex of the curve. Bending films to determine this is the structural curve. These curves are correcting when he's laying supine. And for him, how do you choose your UIV, LIV? One, the shoulders were balanced. I could have said I'd stop at T4, but because the kyphosis went above, I had to go further, and I chose to soften the landing with hooks at the top. As far as choosing your LIV, also I chose just the vertebra that bisects the CSVL as a safe option, particularly that these discs looked healthy on MRI. And you see immediately, like, yes, he had improvement in his TK, but the most profound thing to visualize here is how his lumbar lordosis went from 87 to 45, how now his lumbar spine is seated in a way more relaxed position, and his CSVL, he remained balanced. And the final case is to illustrate that component of an interbody selection. Again, 73-year-old female, progressive pain. If we're looking at this, again, we're starting, pelvic tilt is 70, but if we're drawing the C7 plumb line, it falls behind the femoral head. This is a balanced patient, but she is balanced with compensation. Again, the one point to take from the stock, look at the pelvic tilt. And for her, also trying to evaluate for the need for osteotomy, CT scan, no majorly fused disc. But what bothered me for her was that foraminal stenosis at L4. And that's why I decided on doing an interbody at L4-5 and L5-S1. And this is one of those things before leaving the OR, when you look at this, it's in a way, that's like a 3D capture of the construct. You're able, and in a way, this is not mature to the point where we can do reconciliation based on this, but it gives you an idea of what things are looking like in the operating room. And potentially in the future, we can do reconciliation using this type of 3D capture. And that's her. More balanced sagittally. Again, if we look at the pelvic tilt down from 30 to 20 post-op, her SVA is much improved. CSVL is also much improved. So what does that lead us to, and what does the future hold to? I think the big component, and this is a paper that came out recently of our group about the biological principle of adult degenerative scoliosis. I think a lot of progress will eventually be made into genomics, proteomics, things like that, but also radiomics and how computers and AI and the novel technology is going to help us make better decisions for our patients. But eventually, I put this back in here because I think that obsession with precision, is not gonna necessarily lead to a point where we have zero failure. In a way, yes, we can get more precise, but the patient is still a patient, and we need to, yes, achieve our pre-surgical goal, achieve our alignment, etc., etc. But at the same time, know that there is a lot of variables that we can't control, and try to take that into consideration when counseling the patients and talking to them about this type of problem. I'm gonna end it here, and happy to entertain any questions.
Spectacular seminar, Najib. That's excellent. Those concepts, I think your video will be one of the most watched. You went over, a lot of principles, covering from preoperative to intraoperative consideration and pre-surgical planning, the biomechanics behind it. So fantastic job. Now, in terms of cervical deformity as it relates to primary lumbar deformity, how is the cervical spine impacted? For instance, you showed us that patient with a iatrogenic flat back that you ended up doing a PSO, but he also had a front back cervical spine. How does that impact surgical planning, if at all? Because he's fixed in the cervical spine from C2 to T2, and you're trying to restore sagittal balance. Is there any consideration you pay attention to, or that does not really matter? You just measure the plumb line and do the math.
It definitely matters, but how do you take it into account when you have already a previous cervical fusion is when it gets a little bit challenging. Now, if the overall alignment of the cervical spine is reasonable, in a way you can ignore it. Now it starts becoming more complicated for patients who have like pronounced cervical thoracic kyphosis, and in that case, it would you'll need to take it more into consideration and try to, in a way, understand where that neck is gonna hold after you've corrected the lumbar spine. Now, the question that you would encounter more commonly in the clinical setting is the opposite, where patients might present with cervical issues at the same time they have their lumbar issues going on, and it could be that it's just the problem in their lumbar spine that is and for which they're compensating with their neck. And that's something where, like, using your T1 slope can help point whether this is a problem that is originating higher up in the spine, or this is really a problem of the lumbar spine, and what's happening in the cervical spine is more kind of compensatory in nature.
Yeah, I would mention additionally that when we have patients with cervical spine problems and they get their first ACDF, another radic 88 level ACDF, and the third ACDF, this is the time where it's worth to make a whole upright X-ray from the total spine upright to see whether there is a lumbar problem underneath that causes all these cervical problems. And I just wanted to ask you, when you see a retrolisthesis L23, is this something you try to or tend to solve to find a solution for a retrolisthesis when you have this classic L4-5 degen spondylolisthesis? Or do you say, like I was taught, just ignore the retro L2-3, it's not causing any problems? So our L4-5 degen spondy is so common. We see this so often. What do you do when you see the retrolisthesis L2-3?
So in a way, if I see that as an independent thing, no significant central stenosis, no significant foraminal stenosis, my hope is that if I address the L4-5 spondy with adequate lordosis, that's not gonna become an issue down the road. So I would go for an L4-5, say TLIF in this specific case, try like bilateral TLIF, trying to give them really a good lordosis between L4 and S1, and let it be, and watch that L2-3 retrolisthesis. Eventually, it might become an issue, and in that case, sure, but I feel like counseling the patient upfront that, look, there's this other thing here. It could be a it could be something along the process of your entire spine alignment, compensating for what's happening. And you might need more surgery, but I still would favor a smaller approach. I know people may favor upfront fixing this and adjusting the alignment, but the problem is that we all know fusion begets fusion, and the next surgery is only bigger than the one prior. I'd rather start L4-5, TLIF, maximize that lordosis between L4 and S1, and see if that's going to address the problem, especially if they're coming with something like a radicular type symptom, right? If it's not necessarily stenosis that's going on, like that central stenosis at L2-3.
Yeah, and my next question is, when you have a fused situation L3 down to the pelvis, classic, a little bit less of lack of lordosis, it's a low LDI, so the L3 is not horizontal, and then the patient comes with a adjacent level, and we have this beautiful easy XLIF solving these problems usually. Would you rather go for the next level doing an XLIF with some kind of hyperlordotic cage, or would you say, listen, the problem is lack of lordosis where it has to be. Let's go for osteotomy and fix this problem down there?
Great question and very timely question in many ways, right? Because that is very commonly, like these cases are very common these days, right? People are coming in with adjacent segment disease. They failed because the previous construct is not properly aligned or for some other reasons, and people are going for the adjacent segment XLIF as the solution. In many ways, my feeling is that that's just going to lead to further surgery down the road, I think it is mature to a point where we need to see solid evidence to say something like that. I'm not aware of papers discussing this topic specifically, so I can't tell you, look, based on this retrospective series, that's the likely outcome. But in a way, my impression is just that we're not respecting that idea of lower arc of the lumbar lordosis, upper arc of the lumbar lordosis, we're just going to keep chasing that fusion up and up until it turns into a fusion into the thoracic spine. Especially if you go in there and like you put a very lordotic XLIF cage. Like in that case, that's the outcome is guaranteed that this is going to fail eventually.
Yeah, you're absolutely right. And you know, the XLIF or the lateral approach makes so astonishingly good outcome monosegmental that you have a patient who loves you forever saying, this is the best surgery I've ever had. Length of stay, blood loss, everything like this, won't problems. It's so minimal invasive, it's so nice. And then I'm always struggling. I can't offer this big osteotomy and go into a T10 pelvis surgery. Thank you very much. This was excellent session, and for sure it will be seen a lot of times on YouTube.
Well, I appreciate the opportunity. It's great being here. Thank you all.
You guys, do we know who's presenting next week? If not, then we'll probably know on
It
when I
will
put
be
the flyer
Dr.
together.
Rockos.
Okay, great, Dr. Rockos. Okay, who's hosting him? Do you know?
Toitan will host him.
Okay, sounds good. All right, thank you so much, Najib, for a spectacular presentation, and thank you everyone for attending Virtual Global Spine Conference, and I wish everyone a good evening. Have a good night.
Have a good night, everyone.